to the surprise of many cardiologists, the main risk for a patient suffering from recent onset atrial fibrillation is not stroke. The risk is death. And the risk of death at 1 year follow-up is fourfold higher than the risk of stroke. And the risk of bleeding is a little bit 30% lower than the risk of bleeding of a stroke. So again, main message, the main risk for the patient is death. Stroke contributes to the death rate, but to a rather low level compared to other comorbidities, for example. If you go for the breakdown of the causes of death, stroke accounts for only 10%, maximum even less than 10% of all causes of death. So again, stroke is important, prevention of stroke is important, but the risk of death is not mainly driven by the risk of stroke. Prescribing anticoagulants is absolutely key. And we know that anticoagulation from the cohort 1, 2, and 3, anticoagulation reduces the risk of death by 35%, which is quite strange if you consider that stroke-related death accounts for only 10% of all causes of death. Simply means that anticoagulation plays on other contributors to the risk of death. That may be congestive heart failure, that may be myocardial infarction, that may be cancer disease, pulmonary disease, through keeping control of potential complication of these diseases in the form of thrombosis, and particularly deep vein thrombosis. So there is some kind of an imbalance between the risk reduction for death by giving an anticoagulant and the risk of death due to stroke. So no doubt the risk of stress of death may be decreased because in some patients we prevent deep vein thrombosis or pulmonary embolism, and mostly in congestive heart failure and cancer patients. Now, we have also, if we want to keep at the lowest possible level the risk of death, then we have to consider a completely integrated, holistic or comprehensive management of the patient as you like. In other words, treating patients with anticoagulant is needed. It has to be done for those in need, but we have also to keep control of all the risk factors, whatever they are: hypertension, diabetes, etc., etc., and chronic kidney disease, with a major risk factor for all three major events: death, stroke, and bleeding. ESC guidelines rightly address the issue of the low-risk patients. And the low-risk patients, how are they defined so far? Using CHA2DS2-VASc score, which is possibly not the best tool to define low risk. And we have understood from registry data and data coming also from randomized trials that what the patients that were defined as low risk but possibly in need anticoagulation actually do not derive any benefit for anticoagulation and are exposed to the risk of bleeding. And that's the reason why the guidelines have shifted the paradigm. At the same time, we were developing from the data from Garfield a new risk scoring system taking into account all the data that we have in our database without pre-selection, without pre-definition of the risk, and they were processed by a specific tool, and we ended up with a new risk score that is able to address the risk of death, stroke, and bleeding. And comparing the performance of CHA2DS2-VASc and the new Garfield risk score, definitely the new Garfield risk score performs much better than CHA2DS2-VASc in low-risk patients. And I truly believe that the Garfield risk score has a much better performance and will make it easier for the physician to make the decision. And I also predict that next year there will be an update on the guidelines for the management of atrial fibrillation. CHA2DS2-VASc will be kicked out and Garfield risk score will be in. So over time, we went from a low 60% level of anticoagulation to a high 75% of anticoagulation. That's a good news. And this will definitely have an impact on the outcome. What we already know, we also know, is that the uptake of new oral anticoagulant is increasing over time. What we know also, still 28% of patients are not anticoagulated in spite of a clear indication, and that's a pity. And some of these patients receive no treatment at all or antiplatelet treatment. That's the good news. Increase in the uptake of anticoagulant, decrease at the same time in the uptake of antiplatelet agent, but still a large number of patients are not anticoagulated, and they should be. The bad news is that in low-risk patients, the situation is different, because those who should not receive anticoagulant, according to CHA2DS2-VASc score, do receive an anticoagulation in the range of 40%. This means, and we know now for sure from the data from Garfield, that these patients do not derive any benefit. The risk of stroke is not influenced by anticoagulation, but they are at higher risk for bleeding. The key take-home message from the symposium was about patients receiving antiplatelet therapy. And we know that some of these patients do need antiplatelet therapy because they have a concomitant disease in which there is an absolute need, like recent acute coronary syndrome or whatever arterial disease. But more than half of the patients who are receiving antiplatelet therapy receive it only for atrial fibrillation. And then we have to understand why physicians are doing this, because in these particular patients, aspirin has virtually no efficacy on stroke prevention, not to say not at all, but it has a real impact on the risk of bleeding, and the risk of bleeding with aspirin is virtually the same as the one with the risk of anticoagulation. The next message, take-home message, was about the uptake of new oral anticoagulant versus vitamin K antagonists. And it was shown that it is varying according to regions, according to care settings. For example, the cardiologists are more prone to prescribe new oral anticoagulants compared to the internists or compared to the neurologists, etc., etc. And the last message was about the risk incurred by new onset of atrial fibrillation, and again, mortality, death rate, stroke rate, and bleeding risk. And also the risk, the early risk in patients with new onset of atrial fibrillation. And this is one of the key features from Garfield. We are dealing with new onset atrial fibrillation, means that atrial fibrillation has started less than 6 weeks before enrollment. So we are entering in the field of initial evolution of the disease. And we showed that there is an early risk, very early risk within the first month, maintained till the 4th month, early risk of all 3 major events. And this early risk is linked to an excess of cardiovascular mortality, and particularly previous myocardial infarction, particularly congestive heart failure, and also non-cardiovascular disease like chronic kidney disease. And we come back over and again the same message. If you take care of patients with this kind of atrial fibrillation, giving anticoagulation is right in the right patients, important, but we also need to take care of holistic approach to the management of the disease.